Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can address the controversy around a specific mental disorder named dissociative identity disorder, otherwise referred to as DID. Now, we see a lot of contradictory findings in the research literature about this disorder. This is kind of a polarizing topic. I mainly drew upon two articles for this video. One was an article published in 2014 by Boyson and colleague, and it was a review of a lot of the literature surrounding DID. And another was published in 2015 by Brand and colleagues, and this really took the perspective of trauma as being causal for DID. Now, in order to produce my videos, I usually have to read a number of articles and then add what I learned from those articles to what I already knew from reading articles before or my experience. With DID, that's really not the same situation. I read a number of articles on DID, and it seems like the more that I read, the more clarity that I gained about one perspective or the other, but it didn't really get me a lot closer to an answer. This is a very polarizing topic, and both sides are dug in fairly deeply. So before I get too far into the controversy of this disorder, let me talk about the criteria for the disorder as they're listed in the DSM. So we see that DID is an official mental disorder in the DSM, and in terms of the features, we see a disruption of identity characterized by two or more distinct personality states. In some cultures, these distinct personality states may be referred to as possession. We see a marked discontinuity of self and alterations in affect, behavior, consciousness, memory, perception, cognition, and sensory motor functions. These different personality states may be observed by other individuals and reported to the individual who has the disorder. Now, we also see recurrent gaps in recall of everyday events, personal information, or traumatic events. These gaps in recall can't be attributed to normal forgetfulness. We also see clinically significant distress or impairment. We see that this is not a normal part of cultural or religious practices, and we see that it is not attributable to substance use or a medical condition. The prevalence of DID is thought to be between 1 and 1.6% of the general population, and we know that this particular disorder is associated with a great deal of comorbidity, meaning it tends to co-occur with other mental disorders like borderline personality disorder, post-traumatic stress disorder, obsessive compulsive disorder. We see somatic symptom disorder, eating disorders, and sleep disorders are also comorbid, as well as conversion disorder and substance use disorder. Also, self-harm behaviors and suicidal behaviors have been associated with DID. So now that we see what the DSM has to say about DID, let's move back to the controversial nature of this disorder. I don't think there's any disorder in the DSM that's as controversial as dissociative identity disorder. We see some controversies around a number of other disorders like ADHD and narcissistic personality disorder and borderline personality disorder, but they don't really rise to the level of disagreement we see with DID. With DID, it's not about a symptom criterion or a few symptom criteria or some dispute like that. It's really more existential. It's really more a question of, does DID exist or not? And we also see another large debate around causality. So many people believe that the disorder does exist, but it's not based on trauma, but rather on other factors. These are referred to as iatrogenic factors, and I'll get to that in a moment. Another factor that muddies the waters in terms of DID is how it's mischaracterized in the media. Usually in movies and on television, we see extreme characterizations of DID, where somebody has extremely distinct personality traits that operate for days or weeks on end and have characteristics that are markedly different than the primary personality. So different, in fact, one would wonder how someone would have capabilities in that range. So one personality couldn't have that type of range, but maybe multiple personalities could. That's what we see in the movies. As a matter of fact, DID used to be referred to as multiple personality disorder, which I think also kind of contributes to this problem we see around the mischaracterization and the misunderstanding of the disorder. Now, I think it's important to note here that no matter where somebody stands on the issue of DID specifically, when symptoms similar to what we see in DID tend to cluster together, individuals who have these symptoms suffer greatly. As indicated, we see a lot of comorbidity with this construct, as well as suicidal behavior and self-harm. So this is a destructive set of symptoms, and really the debate over classification is so we can figure out how to best treat individuals with these symptoms. So with this in mind, moving to the controversies, we see there are a few, as I mentioned, and they tend to overlap. The main one is around the cause, and really, as I indicated, this is tied in with the existence of the disorder in general. The main argument as to cause is the trauma versus the sociocultural argument. And sometimes the sociocultural argument is also referred to as the iatrogenic argument. And what this means is that the symptoms of the disorder could be caused by clinicians. Clinicians could be suggesting these symptoms and rewarding clients when those symptoms are manifested, rewarding clients with increased interest and increased attention. So again, we have trauma versus sociocultural, and with both of these schools of thought in terms of the cause, a lot of times the symptoms really aren't in dispute. Neither side is saying the symptoms aren't observable. It's just that the skeptical side, the sociocultural, is saying that the cause isn't trauma and that sometimes these symptoms are being faked, or maybe more on a regular basis they're being faked. But even more so than the argument that symptoms could be faked, what we're really seeing here is that clinicians are saying that clients are giving in to social influence, that our society and the clinicians have really encouraged them to manifest these particular symptoms. So that's really what's at the heart of this debate with DID. It's this causation, not the observability of symptoms. Another debate is the nature of DID itself. So dissociation is a key component, of course, of dissociative identity disorder. And a number of clinicians believe dissociation is real, but they don't believe in the distinct personality component of DID. So really they believe in a slightly different conceptualization of the disorder. So I'm going to talk about these two controversies in more detail. First, I want to mention one last debate that I really won't be covering as much, which is the debate over treatment. So there's also this debate that if treatment is not provided based on DID as it's defined in the DSM, that harm could be done. So here we see two schools of thought. One is it's irresponsible not to believe that DID is real, and the other is it's irresponsible to believe DID is real. So we can see from these controversies that clinicians are really put in a tough position. It's hard to remain neutral on this topic with all these different elements at stake, including the care of clients. So moving back to the central argument of cause, the cause of DID, we see there have been a lot of popular ways to study this controversy. One of the most popular types of research study is taking individuals who have the diagnosis of DID and comparing them to individuals who are simulating the symptoms of the disorder. Sometimes these individuals are trained very briefly in how to simulate DID, and other times they're trained for weeks. So we see a lot of variance there in terms of how well trained the simulators are. Now, an important limitation with these studies that's worth mentioning is just because this disorder can be simulated doesn't mean that DID doesn't exist. This is just one way this particular issue is studied. So what have we found here in studies using dissociative identity disorder and people simulating the disorder? Well, one of the theories with DID is that there's deficits in cognitive processing, specifically recognition, recall, and reaction time. And some studies have found differences between DID and simulators across these domains. One of the problems here is that there's been a failure to replicate the results. And with the scientific method, replication is extremely important. Anybody can have just about any finding in one study. What convinces us that we're moving closer to the truth is when we see the same results across many studies. Now, another area of focus with this controversy is around diagnostic methods. So what they're really looking at here is, if you have individuals with DID and simulators, can diagnostic measures differentiate the two? And again, here we have mixed results. Some studies have indicated that DID can be reliably differentiated from simulation, and other studies have found that it can't. Another problem is some of the instruments. For example, we see studies that use the Rorschach, and it's been found the Rorschach test can differentiate between DID and simulators. But the Rorschach test has been challenged itself. So it's really not the best instrument to use to try to clear up another issue of controversy, like with DID. Some of the most interesting studies, in my opinion, have been around the area of complete amnesia. This has been studied a number of times. So one of the theories with DID is that when a person moves from their primary personality to an alter, so that's another personality state that's different than the primary personality, that complete amnesia occurs, meaning the alter can't remember what the primary personality remembers, and the primary personality wouldn't remember what the alter remembers. Now, some have kind of backed off of this conceptualization of DID a bit, and there's this idea of partial amnesia, but a lot of times we do think of this in terms of complete amnesia, that if somebody's in an alter, in terms of their primary personality, that primary personality is really going through a blackout, and the alter is the entity that's really perceiving and processing information, including encoding memory. So one of the difficulties with this theory is that the research has shown that there is inter-identity transfer of information in individuals with DID and simulators, even if amnesia is reported. So the theory here is there's a subjective feeling of amnesia. So individuals with DID may feel like they're forgetting information, moving from a primary personality to an alter, or an alter back to primary, but actually it doesn't appear to be happening. Other arguments in terms of the cause controversy include this idea that DID is diagnosed all over the world. A lot of individuals have said that DID is primarily diagnosed in the United States or North America, but just because a disorder is diagnosed all over the world, and DID does appear to be, that doesn't mean the disorder is automatically real. Another element of controversy is the relationship between DID and borderline personality disorder. There's a lot of overlap between these two disorders. We know that 10 to 24% of individuals with borderline personality disorder could meet the criteria for DID, and 30 to 70% of individuals with DID would meet the criteria for borderline personality disorder. Now, those that are really defending the trauma cause theory of DID argue that the problem is in the definition of borderline personality disorder, that the dissociative element found in one of the criterion is confusing and has led specifically to this confusion between borderline and DID. We also see some problems with the overlap between DID and post-traumatic stress disorder, but a lot of times this is conceptualized as less problematic than the borderline DID relationship in terms of the trauma cause argument. So what conclusions do we see in the research literature? Well, as I mentioned, we see a lot of contradictory conclusions. On one side, we see that there are a lot of individuals with DID that have extensive trauma histories. So we see a large proportion of that population has trauma histories. So this kind of supports the trauma cause. We also see studies that show there's little evidence to support the iatrogenic theory. On the other side, we see that it's difficult to rule out socio-cultural aspects as etiological, meaning as causal. We also see this idea of blaming skepticism for underdiagnosis, which I think typically isn't well received as an argument. We need to act on our best evidence. So as clinicians at some level, we do have to be decisive, but we always have to be open to skepticism. We have to approach every mental disorder and really every treatment with some level of skepticism if we're going to improve how we understand these disorders. And eventually, of course, that would lead to improvements in treatment. So healthy skepticism is a positive thing, and I worry about that particular argument about blaming skepticism for underdiagnosing DID. We also see a fairly interesting argument that says that misinterpretation is observed across a number of mental disorders. For example, with schizophrenia, individuals believe that the internal experience is actually external. And with body dysmorphic disorder, for example, people see parts of their body which are actually normal as quite flawed. So we do see this misinterpretation. So why couldn't DID also be a mental disorder that has a misinterpretation component? So the bottom line with the research literature is both sides appear to be claiming victory. Those that support the trauma understanding and the really distinct personality understanding, and those that look at the point of view of iatrogenic and see that as more justified. So this again leaves somebody in a really tough spot when they're trying to operate as a mental health clinician and be efficient and be accurate in terms of diagnosing and treating. So what's my opinion in terms of this controversy over DID? Well, this is tough. I think that anybody who is a practitioner or a scientist practitioner wants to try to find out the truth. And I've really read a lot of different studies on this over a number of many years. I've also treated hundreds of clients personally, and I've supervised a number of clinicians, and many of those clinicians have seen hundreds of clients of their own. So I'm partially basing my opinion on my experience, and of course partially on the literature, probably giving more weight actually to the research literature. In terms of the argument that DID is caused by trauma, I am convinced by a number of the items present in this argument, like the link between trauma and dissociation, our understanding of dissociation in general. This concept is fairly well established. It's not always well understood. I also can appreciate the protective nature of dissociation, and I've seen examples where this does appear to be what's happened. So someone goes through a lot of trauma when they're a child, and their brain dissociates from that experience to protect them. And really the thinking behind DID is that this dissociation occurs repeatedly, and it becomes something that comes on when any stress is apparent or when a low level of stress is apparent. So it just continues on, even though it was really originally put in place by the brain as a protective mechanism when an individual was young. I find these arguments to be compelling. Also, it makes sense to me that even though individuals have faked this illness, that doesn't mean that DID doesn't exist. Just because there's malingering on the part of some individuals doesn't nullify the entire disorder. Now, on the iatrogenic side, I'm also convinced by a number of these arguments to some extent. For example, the inter-identity transfer of information. So the idea that the amnesia really isn't happening the way that DID describes. Also, the idea that the media is powerful and social influence is powerful. I'm also convinced that malingering has happened, and again, this doesn't mean DID doesn't exist, but we know that malingering is a problem with DID, particularly when somebody's been accused of a crime. I'm also skeptical that large numbers of mental health clinicians would not see the symptoms of DID, and some mental health clinicians would see these symptoms often, really incredibly frequently. This really leads me to believe more in the expert theory around DID, at least on the side of this argument, which would be that once an individual becomes an expert in DID or in anything, they tend to be committed to that, and it's hard for them to back away from that perspective, even if other information leads them to believe that their understanding may not be true. Also, we can't discount the power of money, of finance. Some experts in DID charge a lot of money to treat individuals with this disorder. So there could be a motivation there to continue to advocate and believe in this classification, even when there's evidence to suggest the classification may not hold up that well. Another argument from this iatrogenic piece that I like is the idea that trauma can lead to dissociation. Again, this is consistent with the trauma argument, but that fantasy and clinician pressure can lead to DID. So dissociation is real, but DID doesn't hold up quite as well as a construct. So I've provided different compelling arguments from both schools of thought, but I really haven't answered the question as to what my opinion is on DID. So overall, I would say that DID does exist, but perhaps commonly in a slightly different form than we see in the DSM. I think this idea of presentations that have distinct personalities is certainly possible, but I do think it's rare. What makes more sense to me is that stress is causing dissociation, and this is leading to dissociated mood states. These mood states, if they reoccur, can appear as different identities, as different personalities. For example, we've all known people that are quite different when they're angry, fearful, or happy, for example. So it makes sense that these mood states can really just become confused with the construct of personality. Again, this isn't saying that DID doesn't exist. I do believe it exists, as I indicated, and it can even exist in the form we see in the DSM. It's just this is so rarely observed, it makes more sense to consider alternative explanations before jumping to a DID diagnosis. It seems rational to me that dissociation exists. We see this, it's fairly common. It seems rational that these mood states could be misinterpreted. It doesn't seem rational to always jump right to DID and assume that we have distinct personalities at work. So again, this is just my opinion on DID. There are a lot of different opinions on this disorder. We really don't know the truth. We have a lot of evidence that points in different directions. And I would encourage anyone who's interested in this topic to read the literature and see what conclusion you would come to on DID. And as always, I'd be interested in seeing these opinions in the comments section for this video. I always enjoy reading the different perspectives on these disorders. I hope you found this description of the dissociative identity disorder controversy to be interesting. Thanks for watching.